Hello, everybody. Welcome, welcome. It is actually Friday night, and we are here with the host of Airway Answers, Expanding Your Breadth of Knowledge, Nicole Goldfarb. Today is her show that I'm invading because we have such a special guest. And I told Nicole I need to be there to talk to Dr. Stanley Liu. Thank you so much for being here, Dr. Stanley.
Thank you guys so much. Thank you.
So we are going to start by introducing our speaker. He is an associate professor of ENT and by courtesy of plastic surgery at Stanford. He is the director of Sleep Surgery Fellowship, Biodesign Faculty Fellow, faculty of the Stanford Center for Sleep and Circadian Sciences, the WuXi Neuroscience Institute Center for Human Performance. He is a fellow of the American College of Surgeons and is on the Young Fellow Speaker Bureau. He has been an honorary professor at multiple universities, given keynote and grand rounds talks across specialties, and over 100 scientific articles on sleep disordered breathing. What an honor. Welcome, welcome.
We are so excited to have Dr. Liu with us today. We have so many great questions for you. Are you ready? Are you ready for all this, Dr. Liu? We're going to hammer the questions.
I am. No, thank you both again very, very much, and it's a really I'm looking forward to getting to know your constituents and group. So I will note that I had just returned from Rome yesterday from the World Sleep Congress. My circadian rhythm is absolutely off. I think you two start cutting me off if that guy is going off on a tangent or. But anyways, thank you. I appreciate being here.
Sure, and we'll wake you if you happen to fall asleep. All right, we've got your back. Question for you before you get started on telling us about the World Sleep Congress, because we definitely want to hear about that. Are you an otolaryngologist, a maxillofacial surgeon? Like, how would you describe what you are? There's so much in the bio.
Yeah, and I think what that reflects really is for those of us who are interested in sleep disorder breathing, sleep in general, you really need a sort of a multidisciplinary background, because I think we've all seen the fragmentation of care, and also every specialty has something so great to offer, but without integrating all of these parts together, it's really hard to direct patients appropriately. So very, very briefly, my background is indeed that diverse. I did do dental school. I did do medical school. I did do general surgery. I did do a maxillofacial surgery residency at San Francisco. And I was able to do an ENT fellowship specific to sleep apnea surgery, and I can talk a little bit about how that came about at Stanford, and that's a very unique and lucky situation.
Did you start when you were 12?
No, I'm a very late bloomer, as you know. And now that I'm in my 60s, no. And so the work. And some of the procedures, as you may know, that I do involves, moving the facial bone around. And there's no way you don't change facial aesthetics when you factor in airway and whatnot. And we should also get into how I think there's a huge misconception about how those are opposite, or maybe not things that we can reconcile, but they must be reconciled. So anyways, so that's where I am. The plastic surgery appointment is by courtesy, and I think where sleep surgery will go, and you've seen some of my former fellows like Sarush and others, where a good example would be, say, a spine surgeon or a hand surgeon. So, in the US at least, a spine surgeon usually comes by way of either neurosurgery or orthopedic surgery, but no one in heck would let you operate on their spine without a proper fellowship, because you gotta know, bone and nerve, I guess, in their instance. So all the surgeons that I train are in that vein, and I think, at least on the surgical end, we are trying to integrate it to the best that we can.
Right. Well, can you tell us a little bit about how the World Sleep Congress was and what went on?
Yeah, so this was in person, after all these years, and I don't know, how many. I mean, in the U.S. we've had more in person meetings this past year already, but this was a big risk they took. You'd be venture guess how many people came actually registered and came.
No idea.
What would be a good number?
1,000? That's a
Like
lot. I don't know.
100, 200 maybe.
Yeah, no. So it was a good. It was about 2,600 registrants.
Yeah,
Yeah, yeah.
amazing.
Uh, Now, a sleep meeting, for in the academic circles at least, the big one, the big American one, the APSS, usually commands about 5 to 6,000. The international one, this one is usually about 3 to 3,500. It's a bit of a newer society. It combined two former societies, but yeah, 2,500, not bad at all. Not bad at all. People, they had the usual, the vaccine checks, the masks and whatnot. So I think the proper precautions were all taken. But really, really good to see everybody back live. Although I don't know what's better. I mean, Zoom is terrible. Like I'm trying to look at you guys. I'm trying really hard not to look at myself. No, I mean, I don't want to look at myself, but I mean, you have to make sure you're still on the screen somewhat. Uh, but when you're lecturing and everybody's wearing a mask in the audience, it is a horrible experience. It's like, are they laughing at me? Do they like me? Are they pissed? What's going on? And so I will say that it's interesting. If you were to date this meeting back even just a couple of years ago, for example, you would hear nothing, very little, about the stuff that we seem to talk a lot about these days. Myofunctional therapy, maxillary expansion. I'll give you a good example. So I chaired the sleep surgery symposium, and I kind of handpicked the best in the world in their respective areas. I mean, I do all these surgeries, but they're folks who are kind of, the face of the thing, if you will. And when the world premier robotic surgeon is talking about myofunctional therapy, and I was like, I almost fell off my chair. It was like, since when? You obviously copied me, but no, it's great. So let's see. I was part of 4 symposiums, chaired a couple of them. So much of what we talk about, nasal breathing, this really wouldn't be there. I'll just put it that way. Let's say even 2-3 meetings ago. So in that sense, it's there. Now, in some ways, it still feels horribly behind. For example, with pediatrics, there's so much more left to be done. And so we could talk more about that. There is obviously emphasis on a lot of like home monitoring type devices, relatively little advances in terms of insomnia care. That's always a tough one. But I would say in general, the happiest thing for a lot of us to see was an emphasis on growth and development. I think the Stanford team has a lot to do with it. Myself and my mentees combined, I think we easily had 20 plus presentations of all sorts. So it was really good.
That is so great. And we're going to get into talking about specific surgeries and what that looks like. But first off, when we say sleep surgery, who does sleep surgery? Are we talking about like a maxillofacial surgeon, an ENT? Like, what is a sleep surgeon?
Yeah, I always, at the core, I think the sleep surgeon has to believe in 2 things. And then I'll absolutely answer your question, because if we look at what we have currently, it's inadequate. But I think after, at least myself, delving into this, 8 years fully practicing, but really been into it since 2005. I think a sleep surgeon has to believe in 2 things. Has to believe in that restoring, actually 3 things, so I'll go 3. Number 1, at the very basic level, restoring airway health in sleep is a gateway to wellness, and you have to believe that. And that's why we're here today. Because I mean, World Sleep Day. You know, if you look at the core theme this year, quality sleep, sound mind, and happy world. Okay, and so you know the mental health aspect of this is absolutely critical. And the second phase, a sleep surgeon has to understand that what we do is not reconstructive in nature. We cannot reconstruct the complexity of airway, breathing, neuroscience, and sleep. There's no way you could do that. What we need to do is to restore form. So that means you have to understand form from a pediatric all the way to an adult, you know, stage. And in restoring the form, it's still inadequate because then you have to restore function. Because things like nasal breathing, readaptation of the oropharyngeal muscles is not going to happen just because you restore proper form. And so that is absolutely key. And then finally, from a technique standpoint, the sleep surgeon has to have the tools, absolutely has to have the tools to balance bite, breathing, beauty, and the brain throughout one's development. Okay, so in that sense, I've trained ENT surgeons to do skeletal surgery. I've trained maxillofacial surgeons to do soft tissue and nasal surgery. So quite frankly, it doesn't matter from what track someone comes from, because everybody only knows half of the picture. And then you ideally want to be able to supplement, you know, your skill set from others. So like I said, I think in the next decade to come, I think all the sleep surgeons will have to have all that tool set. Because of, you know, the patients demand it, and you guys all know the importance of it, and so it just takes longer to catch up because surgery is an apprenticeship. Someone has to hold your hand and you know, walk you through it. So yeah.
And when you talk about the importance of function, that's where all of us myofunctional therapists jump in, because you know, you read so many articles and see so many cases about children who may have tonsillectomy and then are still mouth breathers, still have sleep apnea after, or MMA surgery, and then there's relapse because the function was never addressed. Do you, how do you address function? Do you have myofunctional therapists that you refer to, or how does that piece get addressed after surgery or even before surgery?
Yeah. Man, you raised like 18 keywords, buzzwords there. We could go off on every single one of them, which is awesome. So keep me on track, if you will. By the way, I am drinking wine, but let's here's here. It's Friday afternoon. It is World Sleep Day, and I will tell you that before, and I posted something on Facebook today. A picture of myself and Christian 𝐃𝐈𝐒𝐂𝐋𝐀𝐈𝐌𝐄𝐑 and Bill Dement, who started sleep at Stanford. Friday afternoon, if you want to have a chat with Christian 𝐃𝐈𝐒𝐂𝐃𝐈𝐿𝐿, you got to walk in with one of these. And then he'll sit there and this is and there has been countless discussions over this. So you know, this is sort of in honor of everything. Okay, so not that Stanley. Not that Stanley. In fact, if you want to pour yourself a glass of wine, please do it.
You are on Airway Circle. You're allowed. Yes, we had Dr. Jeff Rouse yesterday. And
you did?
Yes, he had a glass of wine too. He said that you are his hero.
No, I think it's the other way around. But yeah, so. By the way, this is like the most exciting time to do airway and sleep. I just gotta tell you. I mean, it's no. I can't think of a more dynamic time with all the, you know, everybody like yourselves and then Jeff Rouse and everybody else. Too many to name. But okay, let's talk about where should we start, Nicole? Guide me through here. What would be the first? Yeah, cut that question up. No puns intended. Dissect that question a little bit for me and let me start.
Where are we?
Yeah, just addressing function. So I guess we're kind of getting ahead of ourselves, but you did mention that a good surgeon or a good surgery would address the function aspect of remediating the airway component. So how do you address function?
Okay. You know, function is one of these things where First, so as an example, I like seeing pediatric patients or growing patients because I know most of the times they don't need me in the sense that I don't take them to the operating room. Okay, so there were talks at the World Congress where it's about TNAs, then sleep endoscopy, and then like positional therapy. Quite frankly, again, in the end, all roads lead back to tonsils and adenoids. And I'm not saying that doesn't have a place. We'll talk about their place, but it's inadequate. So why is it that I like seeing growing patients? Because in growing patients, there is so much that you can do from a functional level to improve or to direct the form, to direct anatomic development properly. It's only in the adults where all these milestones are missed, where you then have to recreate the form and retrain. So with adults, it's about rehab, and even more importantly, about prehab, right? Which is to say, it's much better if they have people training them, training nasal breathing, myofunctional therapy they actually know, wow, it is, they're really quite inadequate there. Then you do the surgery and you allow a faster return to function. And please do remind me to tell you about my latest research on ultrasound imaging and stuff, and machine learning stuff, where I'm trying to kind of show that on a more objective level. So that's on the adult side. But for the kids, I love showing this movie of a 2-year-old, I think, and CG actually referred me this patient to do a frenulum release and whatnot, and the kid already had the sleep study, and the mom was so cool and smart. She just stuck pieces of raisin up on his developing incisors, and he would just keep picking at it and playing with it. And he comes back and he basically released himself. Okay, so the point is, it is so important. I mean, that interplay is really important. But seeing growing patients is one of the best things in the world, because you can tell them, hey, you have options. And for me, in surgery, and also in an area that where technically surgery is very complicated, but my job is to make the very complicated simple. For me, pediatric care is very simple. You're going to address nasal breathing medically, with nasal sprays and whatnot. You're going to address that, and then you're going to direct them towards good proper function. So just give an example. Everybody's going to say for pediatric patients, and you could go through sleep studies and sleep endoscopies and positional therapy and sleep MRI. Goodness gracious, I would never sedate a child undergo that, because it's not going to change how you manage the kid. But what you're going to do is you're going to say, when the child is like 5 or 6 or even younger or whatnot, expand the child. And there's been countless older studies and newer studies and every kind of study there is to show that you expand the palate, better nasal breathing, tongue comes forward, and that's the beginning of a lot of good things. You take out the tonsils, and the folks with the big tonsils are the mouth breathers, who are narrow anyway. So you're going to take out the tonsils, and then you're still going to expand the patient. So much more ideally, you expand the patient and then see what happens. It's never too late to take out tonsils. Taking out tonsils in 67-year-olds on their path to getting a hypoglossal nerve stim. And of course, that's when the tongue no longer wants to work by itself, and you need like a pacemaker for the tongue. But that's very end stage, right? And we recently have that paper published where after expansion, we saw actually a definitive decrease in the size of adenoids and tonsils. And as you know, that doesn't hurt. Patients tolerate it very, very well, versus bringing someone into the OR. So it's important to think about form and function from a timing perspective, and again, a developmental perspective.
That's great. For just thinking of tonsils and adenoids, now I'm like throwing in a random questions here, because this is
please do.
Okay. Do you think by mouth breathing that could cause inflammation, that could cause the tonsils and adenoids to enlarge and cause obstruction? Or is that, I mean, it sounds like it's kind of controversial and maybe nothing's proven. Is there information like when we restore nasal breathing, the tonsils and adenoids decrease in size? I don't know.
Yeah, so there's so many examples of that, and I also like what you mentioned there about controversies. A lot of times it's very interesting to discuss these things, and whether it's on blogs or whatnot. And I really don't have time to address that. We have patients to take care of, and bottom line is this: some people, some patients, you give them nasal sprays and their adenoids shrink. Right, you're addressing allergies and adenoids shrink. Some patients, as we have seen very successful examples of maxillary expansion shrinking the tonsils. You can always take out the tonsils. Again, the idea is all of these interventions have a role to play. They have, and if one is not effective, you can always move on to maybe a more aggressive intervention, if you will. Remember that some of this is not causal, but just highly correlated, right? When you see a mouth breathing child, especially during sleep, you tend to see big tonsils. And my question is this: we can debate all day what's causal or what's just correlation. But if it's your child, you're going to do something about it, and you're going to do the least invasive thing to get there. And what I'm going to tell you is the least invasive thing also happens to be the thing that avoids them big ugly surgery down the road. So I have a lot of patients, and I look at this and I look at this on the global level, and I couldn't train people fast enough to do all of these things. So if we don't fundamentally treat this as a public health issue and deal with this early on, then we'll operate until the cows come home, and people will go on blogs and talk about wax poetic on how good or bad a paper is. Again, papers are not like golden, like truth. They just happen to be peer reviewed and worthy of a publication and a discussion. And we should discuss everything. But I don't know, as a surgeon, right? Can you just do something about it? Does it matter if the big tonsils is a cause or a correlate or a whatever? I mean, they're a problem. Address it. So yeah, I mean, I think those are really good questions to kind of think about, especially if you think about their other non-invasive new technology to address all of these things. But sleep is universal. In some ways it's complex, and in some ways it is not. And we shouldn't make this issue any more complex than it could potentially be.
I do have a question. We do have moms all the time. For some reason, a lot of my patients' moms, we're like me, myself, we're all crunchy. We call ourselves crunchy mamas, that we're a little bit more holistic, the way that we try to do things, and, no toxic stuff. But a lot of these moms do not want to take tonsils out. That, they're always trying to run away from it, and they will try anything under the sun before they decide to go for surgery. Some of these kids have grade 3, grade 4 tonsils. Is there ever a time whenever the tonsils are that enlarged that you as a surgeon would say, let's try something else, let's see? Or whenever they are that, grade 4, you say, they're not breathing, we got to get them out right away?
Great question. And there are all these guidelines everybody can read and download, and they change every so once in a while. But on the practical point, this is what I would say. If the tonsils are really that big and you can't find anybody to expand the palate, or the palate is just somehow perfect and you happen to have huge tonsils, and this is very early age. Let's say this is age 1, 2, 3, whatnot. Yeah, the TNA, great. Or you're in a country where you don't have resources, or you're here in the U.S. and you don't have the resources to see someone to do that, then absolutely, anything is better than nothing. And when it's done at that early of a stage, that can still help drive, right, good facial skeletal development. So that's okay. So a lot of this is just practical stuff. I mean, I see this every day. But, say when it comes to age 5 or 6, and you do have that option to go either way, by all means, if you can, go for things like expansion and establishing nasal breathing. Expansion is not the only way, but I'm just saying, nasal sprays, allergy control. I'm just saying the whole rubric, okay? But then again, yeah, I mean, in a lot of developing countries, for example, and this reflects on the adult side as well. CPAP being the first line of treatment, and I still argue if CPAP is even a treatment, is true, is driven by big pharma. Because if you're in Thailand, if you are in South America, if you're in a lot of places in the world where you have to buy your own CPAP, surgery becomes first line treatment. Never is any one entity by itself completely always adequate. But I'm just saying that the order of which, and that's why the new Stanford, sleep surgery algorithm that I've worked on over the number of years, it really incorporates everything, but it is on a continuum, because also the patients decide where they want to start on that path as well. Coming back to your question about moms and whatnot, there's nothing wrong with trying everything conservative that you can to improve sleep disorder breathing or breathing in general. There are only a few, I think, critical time points, though, where you have to look out for. Things do change after one reaches skeletal maturity. Unfortunately, we're not quite sure when that exactly is, right? And for boys, I don't think I reached maturity, until like a few years ago. So, with guys, we don't have the science to know that, but you just got to know that, towards the adolescent stage, things become a little bit more complex. If you fail conservative treatment, you want to start thinking more. And this is also where then we've been driven to do more minimally invasive approaches to doing things, because it is an unmet need, if you will, for our population.
That's a perfect segue to talk about what are the different types of sleep surgeries, like different ages, what kinds of surgeries do you do from childhood through adults?
Yeah. So you want to start with the kids first, like let's start with the very young. Yeah, the super young. Yeah. So and maybe we'll divide it into, and because there are algorithms and maps on this, but let's just think conceptually, right? And then again, before we get into the individual procedures, I want sort of our group not to get caught up in the procedures themselves. But remember, it's a whole system we have to restore. So here's the system, right? Whether it's a 2-year-old or an 82-year-old, right? We want nasal breathing during sleep. Nasal breathing causes the upper airway muscles to, right, with the negative pressure, causes it to collapse. Now, what supports these soft, the upper airway muscles is the facial skeleton, okay? This entire system has to be restored if we're going to see any results. So if you just address nasal breathing and not pharyngeal stuff, not going to work. So let's start with that sort of context in mind. Let's start with the very young, okay? With the very young, you're not going to have pharyngeal collapse because the muscles are not, the airway is relatively short and they're not so floppy. So that's why in the pediatric population, the pharyngeal stuff are the big tonsils. And it could be the palatine tonsils or the lingual tonsils. Okay, and up above, of course, we're talking about establishing nasal breathing for all. So for kids, what do you have, right? You're going to do conservative nasal treatment. People really don't want to operate on the septum unless there's just some obvious, humongous, horrific, deviation of some sort that you'll do something very, 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 very limited. But even then, we're really not huge fans of that. Okay. And then for the very severe, let's say, the Pierrot band kids or whatnot, you do have mandibular distraction. But really for the everybody else, you're looking at tongue tie, you're looking at, ability, all the breastfeeding stuff that everybody fortunately is really, really in tune with, and training oropharyngeal musculature. I kind of joke about it in clinic with my patients all the time. But it's like, what's the problem with my world, Silicon Valley, Palo Alto, Stanford, right? Unfortunately, we may have kids born premature. We may have kids born and moms have to go back to work relatively soon. Maybe they're not breastfed, for long enough. And breastfeeding is amazing, right? Because you've got tongue pushing up, expansion of the palate, opening up the nasal passage, the soft palate has to seal, and then you have to swallow. To your population, that's like obvious. To most, it isn't. And by doing that process, you've just done everything that I do surgically for adults down the road. I can tell you, all the ones that missed out on that one. Okay, so that begins this entire process. Actually, who did I speak to recently about this, and out in Rome, and they were so shocked. They were like, you know what, that's right. And yeah, I mean, evolutionarily speaking, that would be the best way to start, you know, everything. Okay, so then if that's the construct for peds, what are you thinking, right? So I mentioned very, you know, medical treatment, conservative stuff, very conservative septo if it must be done, maxillary expansion, beautiful, tongue tie release, myofunctional therapy. And then only for the syndromic kids, you might do some distraction of the mandible, right? And you're kind of done. Like, is there really more to do? Cutting out a piece of the tongue is not the answer. I know it's done, but the tongue, right, is driven by the genioglossus muscle, is one of the most powerful dilator muscles of the upper airway. Cutting out the tongue is never the answer for a 2-year-old or an 82-year-old. And I have a ridiculous analogy I always give my patients in clinic. And this is a really bad one, so bear with me on this one. If I were to wave goodbye to someone, right, and my triceps, I don't know what the term is, but they're kind of floppy, they swing, it doesn't look so attractive, okay? Our response would be, well, you should work out, you know, and lift and be more toned, right, with your tricep muscles, and that should address the issue. We don't say, well, when you're waving goodbye to someone and the triceps flopping around, let's just cut that tricep off. Let's just cut it off, right? But that's what people do. You cut off a piece of tongue, or you cut off, like, after the tonsils, you do a U-triple-P that removes muscle. That's what you just did. You just took it out. And that is just, right? And then patients always get that, you know. I mean, patients understand a lot. I mean, I take a picture, you know, of a scope. Before I scope their nose and the throat, I just have their mouth open, take a picture of their intraoral cavity, their oral cavity, and, you know, tongue's this wide, the palate is this narrow. From like 4-year-olds to much older patients, I just ask them, hey, do you think your tongue fits in there? And they're like, no. I'm like, yeah, I mean, it doesn't. You know, when the width ratio is like 1:7 or 1:5, it really isn't going to fit, right? So the tongue's only got 3 places to go. It sinks into the airway, it sticks out of the mouth, or it doesn't fit inside. I mean, you know, so it's just funny that I have to go to academic meetings and argue with people, not argue, but, you know, make my case for it. When every human being can see that, look, it doesn't fit. What's the issue here? So anyways, so for kids, that's relatively simple. And we don't cut any muscle, and we would never do that. Okay, let's say you're now marching up the age here now. There's a ton of discussion and a lot of, you know, discussion back and forth about ways to expand the maxilla, and I'm happy to see that. I think, you know, it's just like there's like so many different ways people talk about doing palate surgery, tongue-based surgery, MMA surgery. Finally, there are all these different ways where people talk about expansion of the maxilla. I would just say that if you can expand it non-surgically, do it by all means. That's why I always rush patients. You know, I'm like, whoa, you're 12 or 13? Go do it quickly, right? Because this is still a stage where you can expand predictably, minimal, complications. Things will go well, right? When you're 55 and a half to do it, it's just not going to be great. And we know that. It's just not going to be as great, right? Because you've also wasted 55 years of bad breathing, which is just not great, period. So you go through, you do have that phase. Unfortunately, at that phase, we're also limited in the sense that if there is AP, so anterior-posterior discrepancy, we can't do much about it because folks are still growing. So that's where you do have to hold. And that may be a place where things like CPAP does have a role, because you're in holding pattern until you can do something definitive, okay? Let's say you reach full adulthood. What are you looking at? For the nose, okay, I address internal nasal valve, the most restricted part of the nasal cavity. That would involve septum, inferior turbinate, upper lateral cartilage, and then everybody misses the nasal floor. But anyway, that's where what you would address on the nasal level. In narrow patients, again, we have like an 8 or 9, 10. There's a timeline of papers we've written about maxillary expansion where it goes from why we do it, how we do it back in the old days, how does this work, to how do we do it today, and what the patient responses to it. Okay, and so there's an entire series of literature behind it, and then how then we try to have our nasal and oral muscular dynamic function to adapt to it. That forms the basis of very successful other surgeries, because now when you remove tonsils, do a nice little nip, and not nip, but just a tuck of the pharyngeal muscle, to MMA surgery, to hypoglossal nerve stimulation for the tongue, if the tongue doesn't even want to move anymore. I mean, that's really kind of a bit of a sad thing. But at some point, your tongue is so tired, and we should get into that, Nicole. We mentioned that about the tongue getting very tired in our younger population, probably the most underserved of all population. Then we might have to throw in the hypoglossal nerve stim. And so there's so much that goes into it, and you just have to be aware. Just 2 weeks ago, had a wonderful patient, had a great MMA surgery. Then after the advancement, you realize that what was a minor tongue tie really looks like a big tongue tie. Release that guy, and that guy was compliant with myofunctional therapy. He came back 4 years later. He has an AHI of 0.2. I've never even seen in an in-lab study.
Wow.
I've never even seen that, right? And so that was, anyways, I'm just saying this whole system has to work well. And more important than looking at individual procedures, you just have to understand that it all has to work in the system, okay? And you go to surgeons where they say, well, this is the trend of the fashionable trend, if you will. We're into tight suits, or we're into baggy suits. So today, everybody that walks in, you're going to get say maxillary expansion, and you're going to get the same one every single patient. And you guys know that's not true. I mean, when you train people to do myofunctional therapy, you're going to have to adapt your teaching style and things according to where the patient starts. And how fast the patient is progressing. But anyways, this is kind of where I just think, I don't know. It's like that nice book, Good to Great. Good to Great companies set their goals and strategies based on understanding, right? How to understand where our patient's from. Comparison companies set their goals and strategies based on bravado. And you guys, I'm sure, in your field, see that plenty of times as well. So, I mean, we can get into much more specifics about the technicality, but I hope my role is a lot more to define the philosophy and the concepts, because that doesn't change whether you're 2 or much older.
Yeah. And it's really clear that you're saying you're not doing a reconstruction, but you're restoring what should have been. Like, that's really gives it a really good big picture. In terms of maxillary expansions, could you talk about the dome and the mini dome procedures that you guys do at Stanford, and the mini dome being, I think that's the newer technique? Yeah.
So what began as a technique, maybe a little bit of history may be helpful, and this was 2000. So I finished my fellowship in 2014. And I think 2015, Christian Guilleminault, CG, approached me about expanding adults. And I will be totally honest, I had no idea why. I don't. I mean, he at that time, I recruited my very, very good friend and colleague, Dr. Audrey Yoon, to help out. And initially, I asked her to help out because Stanford has nothing dental or orthodontic. Like it's just, at Stanford, they I don't know, must believe that people don't have teeth or something. And so I'm like, well, shoot, I need, because at that time is more for MMA surgery, and I want to have, have it be both cosmetically appropriate, airway driven. I just thought she'd be a perfect candidate to partner up, and she did. So I introduced her to CG, and I still remember the afternoon so clearly. No wine in that afternoon. Oh, I don't know. But like they started drawing. CG started drawing these pallets with these like like screws, and I think I was running around doing stuff. And I'm like, well, look, you guys chat, and whatever you need me to do, I'll be there. So that really began in 2014. Expansion of these adult patients, and quite frankly, I'll also be honest. At that time, that fell on my laps because I started as a full-time faculty. I'm like right there. My office is 2 doors down from his. And at that time, no one else wanted to do it. Okay, so then you know, as a young, I love to associate my word with the word young because I'm no longer young. But as a young surgeon at the time, I just thought it was awesome. Okay, so that's where we started. And so the techniques were, you know, then you dig into the older textbooks and you realize, man, nothing but pretty aggressive surgery, and the results were not very good for at least for nasal expansion's sake. Okay, so anyways, that's why we, for about a year or two, Audrey and I really worked on using various forms of orthodontic appliances and adding surgery. And initially, whether it's a little bit of surgery or more surgery, anyway, we came down with sort of a nice protocol of doing it. So that was 2015. Concurrently, one of my former fellows, Ryan Williams, who was an ENT resident in my program, did the surgery fellowship. I don't brainwash people, all right, but he did then go back to dental school and is finishing oral surgery at Harvard. So, look, nobody in our field who really does this for real, you know, like forgets both aspects are really important. But anyways, he did a great study with me where we dug up all these patients with cone beam CTs for sinus reasons, and they had septoplasty. And then they also had like a questionnaire, which, by the way, questionnaires are key for nasal obstruction, right? Before, after. If a patient tells you they're breathing better, they're not lying. And if they're telling you they don't breathe well, they're not lying either. So just, you know, this is important. Anyways, and that's where we found that the narrow high arch patients, even after nasal surgery, don't do as well. So you see how, so these two start coming together. So then now we evolve into, okay, so, you know, looking at airflow, how does it change the internal nasal valve? I mean, we did it all. CG at the time actually had us do a study where we put rhinomanometry down so that we get a sense of nasal airflow. And I know some of the audience is going to say, well, it's not reliable. This study says that and that study says that. I know. But we can, you know, talk to me about that.
Rhinomanometer or the rhinometer? Because there's a difference, right?
Yeah, so this was see the program is written in Czech. Yeah, CG got this thing from Europe, but it's a rhinomanometry. So this is at least how this was done. We plug one, guy wears it, breathe in, send out, see the flow. Okay, yeah, and yes. It is not consistent because, you know, everybody can use a different, you know, effort and whatnot and blah, blah, blah. I get it. But we did use those actual flow for the purpose of a computational fluid dynamics study where we were then floating that actual patient's flow through their pre and post CT scans from maxillary expansion. Yeah, I know some in the audience is going to say, well, CFD assumes the airway doesn't move. Look, I know this, all right? But look, and then you do something. But we're just saying that, look, it does change because a slower airflow through here there is less negative pressure. I mean, you got to explain why you're doing something. I'm never going to say that I'm right or wrong, you know, about something, but I'm just saying at least we published it and it's worthy of a discussion. All right. So we did that. We looked at the internal nasal valve. And this is also when you start to circle back then and say, well, this kind of works. Now what? Right? Because there are issues, you know, an expansion that's too big, or how do you control front to back? Then there's this whole other discussion about, well, my technique expands the front, my technique expands the back. And I'm thinking, well, the patient needs what the patient needs. And you have to try to be patient specific. So then what evolved next was then the endoscopic approach to it. Because if I'm already operating inside the nose and I'm doing septoplasty, turbinate reduction, probably nice to avoid other incisions for the patient. And so then this is where the endoscopic approach started to happen. Okay, key thing about dome, and again, dome might have started as a procedure, but if you look at the name and the way I do things and look at how it is now, it is a concept. Distraction osteogenesis, right? We're trying to grow bone, like right here, underneath the nasal floor at the nasal maxillary complex, right in the middle, right? By way of maxillary expansion. So it's not your tilting. It's not, you know, moving, you know, maybe just teeth around. I mean, there's a full, we're trying, this is our goal, okay? And so then it led to the endoscopic approach. Then it led to using virtual surgical planning to say, okay, well then let's look at the thickness of the bone. right? Because some surgeons will tell you, I must do this or I always do this. Well, not really, because patients may have different bone thickness and the anatomy is different. And we haven't even gone into gender and ethnicity, which is another whole, a thing to consider. And we do publish on that as well. And so in order to control that, we want a level of precision so precise to leading to the mini dome, which is, again, and by, look, I am in the Silicon Valley. If you're going to roll out with a new phone, well, the iPhone 1, 2, 3 is not really all that, creative either. But you got to roll out something cool that comes out with your new thing, right? So today we're talking about something that's virtual surgically planned with guides and endoscopic in approach and designed specific to the patient's anatomy. And even with that, we're not always successful. So I'm just saying, I'm very, there's a level of humility about it, but we're trying. So the mini dome is now very patient focused in that, and also doctor focused. If the orthodontist or someone says, look, the patient needs both anterior and posterior, we're going to do it in a certain way. If we are focused more on the posterior, we'll do it in a certain way. If we're going to focus more on the anterior, we're going to do it a certain way. And then based on that, we're going to continue to improve on the technique, because there's no doubt that I know 5 years later, this is going to be better than this version. But I still believe in this version is still better, because we're now veering towards more and more, patient-centric and precision surgery. So think of dome as a concept. It is important when you're 55 years old. We're not going to expand this very easily like you would, in a younger patient. But that is the approach, and using all the right technology. So to make it better, we published a series. Most recently, we published the one where patients had septoplasty, and then they didn't respond, and then they had the mini dome, and things worked out. But see, that goes back to full circle, right? To where we started 6 years ago. Okay, to help my fellow ENT surgeons, what I'm about to do with this is this will be plugged into an actual protocol where they can just send in the cone beam. So say you refer a patient, they can send in a CT scan. Johnson & Johnson, Synthes, or whatever company, but we're working with Synthes right now. They'll align these patients and basically then, kind of go through our protocol, spit out the guides, send it to the patient, and I'm teaching ENT surgeons how to do this procedure properly. In fact, one of the most exciting things is dome is actually canonized into the rubric of ENT sleep apnea surgery, and one of the newest things, and folks are very excited about it. So anyways, that's the history and kind of progression, and the future is exciting. Now, coming back to where we are, though, restoring the form isn't, it isn't adequate. And then this is where then the functional aspect has to catch up.
Sorry, go
ahead.
ahead.
Ask one thing about the mini, because I just thought,
Yeah.
is the mini dome, since it's like a newer, less invasive procedure, is that replacing dome, or it's kind of two separate things?
It's like two ways to look at it. Okay, you say you have the latest version of the iPhone with all the functions involved, right? And it's great, and you can, and it's very good. Doesn't mean the iPhone 10 is completely worthless and cannot be used. I wouldn't go back to the flip phones, if that were the case. But so I think there is a progression. For example, we still have to keep in mind, in some countries, right, doing this endoscopic guided virtually surgical planned thing is very expensive, right? So one caveat: every procedure that I've ever written about and I talk about are all covered by medical insurance, right? I'm a faculty member, and I have the luxury of looking at the patient in the eye and say that I am really trying to do what I think would be the best for you, and we're going to making this decision. Right? There is no financial incentive in mind whether I do a mini dome or whatever other form of procedure. Okay, and so I would just say that we will veer towards a mini dome almost all the time, but occasionally, let's say if there are redos, or say the patient has not succeeded in expansion with other methods, we might revert back to the older version just because of better visualization, or an open approach may still be necessary. A very easy to remember example may be this, or analogy. If someone has a gallbladder infection or appendicitis, almost always is an endoscopic approach. And it used to be 2 or 3 holes, and now it's like 1 hole through the belly button, you know, whatever it is. But if that thing blows up and is infected, you're still gonna, you know, do an open approach. So anyway, all surgeons should know all approaches, and so when I teach these courses to surgeons, we go through all the approaches.
Okay, makes sense.
Yeah.
Going a little bit deeper into septoplasty and nasal surgery, I have heard, and I'm not sure if this is true, is there ever an instance where somebody has had nasal surgery and that will prevent them from having MARPE or dome or any type of surgically assisted expansion afterwards?
I can't think of much. I really can't. If the patient has had nasal surgery, still can't breathe and comes to you, perfect. That's the patient you're going to expand. I mean, so, right, because you're assuming everything else has been addressed. The septum's been addressed. You know, we've done open nasal valve surgery. Inferior turbinate has been addressed, and we're talking about not overly addressed, because overly addressed, then you get empty nose syndrome. That's another whole bag of things you don't want to go after. But no, it's actually good. And let's go one step beyond anatomy, because people always talk about anatomy and say, oh, okay, so you expand, the nasal patch is bigger, people breathe better. No. It's not just that. You're increasing surface area. And increasing surface area of what? Of nasal mucosa. And that's a lot of good stuff. There are receptors there that senses temperature, right? Nitric oxide production. When you sleep and you nasally breathe, the dilator muscles respond. This is crazy stuff. In fact, there's a red binder you see back there. And again, I hate going back to history because it just keeps reminding how old I am. But unfortunately, after CG passed away, there was no time, I guess, for folks to clean out his office. And Stanford was about to clean out that office. And so they're like, well, and so folks went into his, office to kind of, keep like photos and memorabilia. But I went at these folders are insane. That red folder had stuff he was reading in the 1980s about dental stuff and nasal stuff. I mean, it's just unbelievable. He was already thinking about it way back when, before, and now we're all doing it. What, 30, 40 years later? But these ideas were very much already, in mind, okay? So one of the coolest papers in that pamphlet dissects out all the upper airway muscles and which ones open and which ones constrict during sleep breathing. What the hell? But you can only do these studies back in those days, by the way, because you literally stick a needle in that thing. Who the heck? I mean, although, remind me about my ultrasound research to tell you about that later. Okay, so I even challenged some of the folks like doing the palate surgery. I'm like, I have a question. When you sew these things, all together, some are dilator muscles and some are constrictor muscles. In fact, the name is literally superior constrictor. Just like, and they're like, oh yeah, I just captured it to close dead space. And I'm like, but they're going opposite ways. But anyways, point being that nasal expansion is not just, nasal maxillary expansion is not just about size or anatomic structure. You're creating more of the mucosa and the physiology there. That's really, really quite exciting. And later on, let's say if the patient did need double jaw surgery, once we have access to the maxilla, opening up that sinus drainage, clearing out the sinus. Oh my God! And then we publish on this one too. Even in our old days, right? 17% of patients needed some form of nasal intervention after MMA surgery. Way down to less than 5% because of all the things that we focus on with nasal breathing. So, anyways, I would just say that post-septoplasty, they need your help. Go for it. Not the because you're if anything, you're growing them. What they need, which is nasal mucosa.
Do you ever notice if someone has nasal floor expansion through like MARPE or dome, and they did have a deviated septum prior, a septoplasty is no longer needed because you've just expanded the nasal volume? Yeah.
Yeah, so I've seen it both ways, and here's what I'm going to tell you. In the beginning, when we started doing, dome for adults, okay, and again, remember, it's just a concept for those of you who log on later. Whether it's pediatric expansion via Invisalign because you're so young, or later on with MARPI, later on with dome, doesn't matter, okay, and then whatever names that people who came late to the game, come up with. The key to this concept with the expansion is that initially when we were doing it, we didn't address the septum. We just went boom. Okay, we just expanded. Okay, and a vast majority of them did not need that septoplasty. Now let's think back to why septoplasty would even be done, right? Let's think function. Only if it blocks breathing, affects breathing, would you do something about it. If it doesn't, then it does not matter. Nobody needs a perfectly straight septum. All right, nobody needs that. It's just that when your nasal wall is this narrow, then any little bit of deviation now suddenly looks like it's very, very significant. One key caveat though, remember that the septum in the anterior is cartilaginous and in the posterior it's bony. And so the only thing that we learn in our experience is that as you expand, then the posterior part that's bony will expand with you. It's bicortical. So let's say if you're deviating this way, then you expand the back and it's going to go this way. So you do have improved nasal breathing, but one side's still way better than the other. Then going back to do a septoplasty on that bony area is just not as good of an idea. You don't want to torque the thinner bones up high in the skull base. I mean, we avoid it. I'm just saying it's not as great, okay? So I think for, if you do know that there is significant posterior deviation, maybe a good idea to do the septoplasty either at the same time with expansion or do the septoplasty and then do the expansion. Not a bad idea at all. If it's anterior and it's cartilaginous, really doesn't affect anything. And if you do need septoplasty, then it wouldn't just be a simple septoplasty. If it's way anterior, you're going to do an open anterior septal reconstruction. Again, not a tremendously difficult thing, but it impacts what we do on the expansion level a lot less.
Wow. That really shows why the ENTs need to be working with the orthodontist or who's ever doing the expansion, because if they're not communicating, it sounds like there is a better order to doing these things. So that's really good to know.
There is an order to it, and I would say that, and this is where the cone beam CT is not going to be enough. Because the cone beam CT, you're going to see the skeletal part, right? You're going to see the bony part of the septum, which is more posterior, but you're not really going to appreciate what's happening up front or up higher towards the internal nasal valve. So, and this can be taught. By the way, guys, I go to dental meetings, right? And they're like, where are the ENTs? I go to the ENT meetings, and the forward-thinking ones, and there are many of them now, they're like, where are the dentists? I'm like, where do you work? And I'm like, I think I might know someone for you. And so that's why, for example, things like the Airway circle, I think, again, I feel super fortunate because I do live in this intersection. And so amongst which I kind of know where folks are. We just kind of have to, I still believe in most part of this country, if we have little hubs, of orthodontists, dentists, myofunctional therapists, ENT surgeons, if we had little hubs like this, you guys can address 90% of the patients. And then you'll then send to the tertiary centers like Stanford what really might need more potentially, right? I mean, that's how healthcare is supposed to work. And I'm seeing this happen, by the way. I am seeing this happen. I'm super excited. I think in the next decade to come, this network will come to fruition.
Yeah. Couple more questions about septoplasty. If someone needs a septoplasty and MMA surgery, do you do them at the same time? Yep. Okay.
Yeah. Great question. So most of the times, by the patient gets to us, a lot of times, right, they've already had everything done, meaning they've done the nasal surgery. They may have done, some kind of soft tissue palate tonsil, whatever it is, okay? So in that case, you have no choice. You just do it. That being said, when you move bone around, it always affects the septum, and you have to control that because, we're going back to function, right? You do a good double jaw surgery, that is good at fixing the pharyngeal part of the airway, and I published that. We looked at it with sleep endoscopy to show how does it change, and it really supports the velum up high, the soft palate, and stabilization of lateral pharyngeal wall, which is one of the hardest things to do. However, you know, if you don't address the septum and you do a jaw surgery and it kinks the nose, and you're dead, because that patient's going to mouth breathe and you're done. You did this big surgery, they don't feel the improvement. So it's critically important to address that. And so during MMA surgery, and we publish on that, we, you know, by the way, I write all these techniques, and it just makes me sad sometimes because people don't like to read. I know it's boring, but just read it or call me, because I will tell you exactly what to do. There's nothing to hide here. But do it, because if you don't establish nasal breathing, patients aren't going to do well, especially not the ones that I operate on with sleep breathing disorders. But you can absolutely do it at the same time, at least on the lower part, not way up high in the nasal valve. That would come later if you're going to do nasal valve surgery by itself. But you can absolutely do it at the same time with very good effect. So I don't know. I don't know who's going to eventually listen to this, but I have textbooks with the videos, I have papers and whatnot. Just tell me if you want it. I'll just give it to you. It's important. This is very important. Otherwise, how do we expect then the patient to retrain nasal breathing when you've just blocked up their nose? So if you ask my fellows, when the patients come back from their post-ops, I walk up. It's fine. Patients start to like open their mouth. I'm like, oh, stop. Yeah, I'm just gonna look in your nose. Yeah, because you know the quality of the double jaw surgery that patient had by looking inside the nose of that patient post-op. If it looks good, something correctly was done, right? If it's the old techniques where septum wasn't addressed, the inferior turbinate is clamped off, and they cut off the whole thing, and that is in the textbook. One of the major textbooks, and please by all means don't do it, because you're going to create empty nose syndrome. You're going to lose all the mucosal support. Just don't do that. But the answer is yes, to some extent you can. But remember, septoplasty itself isn't one procedure, right? There is more. You know, you address it depending on where the septum is crooked or a problem. Okay, so during MMA, you can absolutely address the lower part of any septum that's deviated or potentially an issue.
I have two questions.
Yeah, please.
One, what are some things that could cause the septums to be deviated? And after having it corrected, can it get crooked again? And then the second part of the question that is not really related, but I wanted to ask you about torus, palatal torus. If you see them most commonly in certain patients, and does it have, somebody asked yesterday, does it have to be removed in order for them to do expansion? But how is that all related? If the torus is related to anything in that midline? Great.
I got the torus part. You were saying for the first part, so with the septo, if it's crooked.
What causes the septum to be deviated? And after somebody has had surgery, can it deviate again?
Yeah, man, I've been really into this nasal. I'll tell you an interesting thing that kind of happened during the pandemic. That's really kind of cool. So remember, during the pandemic, folks come in and they wear a mask, right? So I'm kind of running around patients, and so then my fellows would go in, they'll scope the patient, but I walk into the room and the patient's mouth is still covered. Okay, so I can't see their face, I can't see anything. All right, so then I start by going through the scope, and start looking, and then you see these, some people have these horrifically deviated septums. Now, sometimes if the septum falls off the maxillary crest, that's almost trauma, and then, so I would just ask them, like, whether it's an athletic injury or did you just have like big brothers, growing up, and whatnot, and so when there are times when the septum is so kicked off that there had to be trauma of some sort. Sometimes though, and again, any normal human being would have some degree of deviation. Again, it just depends on whether it affects them or not. If it's way up high near the upper lateral cartilage, that could be a problem because when you breathe in, this collapses. If let's say it's really like deviated in the back and it butts into the inferior turbinate, that's going to be a problem because the guy's going to be breathing through 2 little ports inside the nose. So some of this stuff you do see, and it's fairly common. But I think the more interesting aspect of all this is I will look at it and go, wow, the right side is way more blocked than the left side. And this is when I start taking bets with my fellows. But I would only bet $1. And I would tell them, I'd bet $1 that there's going to be facial asymmetry, and that one side of the face is either going to be longer or more hypoplastic, less developed. Patient takes off the mask, and literally, I mean, I start going off their life story. I'm like, yeah, no, this body's not as good. So you had this asymmetry, the orthodontist tried to correct it, blah, blah, blah. Or that asymmetry persisted, and then the lower jaw has to match it. So I bet your joint started to click this way first, and then this one hurt more, but now this one hurts also, and that one doesn't click. I mean, they're like, what is going on? And they take off their mask. And so this is what I teach fellows all the time now too. For a sleep apneic patient, right, they're not coming in for sinusitis. I mean, they may have the chronic, but your nasal exam, and by the way, this applies to all of you too, your nasal exam does not begin with you sticking something in someone's nose or using a nasal speculum. Your nasal examination begins the minute you walk into the room, you start talking to the patient, and you notice facial asymmetry, and you're going to start thinking, and I'm talking about mid-facial asymmetry, but this develops first. This is going to follow. And so you really have to reckon with it, and boy, just look into that. 2 things you have to look at: their posture and facial asymmetry. By looking at those 2 things, you absolutely know how long they've been dealing with this stuff, okay? So I'll circle back a little bit to your question about septoplasty. But let's say you're born with a crooked septum, okay? Then those kids have always breathed poorly from one side versus the other, right? So they're going to rely on that one side. Guarantee you, that side of the face will be more aerated. That's going to come forward. It's going to come wider, and this one's going to be rotated this way. So now your upper jaw is going to develop this way, and now your orthodontist is going to have to try to correct it this way. Okay, and so now you have all this asymmetry. Just trust me on this one. Go look at your patients. Now there are several ways to look at midfacial hypoplasia. More scleral show, meaning the white of the eye. This eye sunken in. Or long face. Remember, blocked nose, you get the long face. But then you're like, well, then who's hypoplastic? Who gets a long face? This one I haven't published yet, but this is going to come. I'm going to tell you what it is. It depends, again, on what stage it's going to be. Born at birth, if it's that bad, the whole thing doesn't develop. The whole chunk is going to go back. Say it's nasal allergies that you develop because you moved from a cool place to a boring place like Silicon Valley, okay? And then one side is more blocked. Then you're going to get the long face. Okay, so because if you think about it, that's just how it progresses. All right, so now how do you correct that? You see, here's the ridiculous thing. You know, say an oral surgeon looks at that, goes, "Oh, you have maxillary symmetry. Then we're going to correct it." Well, that's not interesting to me, because if you correct it and you don't correct the root cause of it, again, moving a bunch of jaws and teeth around is really not very exciting nor difficult. The more interesting thing is, how do we get there? And that's why, anyways, I'm just saying. So, and I'm sorry I have very long-winded answers to your thing, but just, you know what? By the way, come visit me one day in clinic, because like right before I flew for last week's meeting, like I was like, in one day you'd see the whole gamut. You just see everything, and everything I'm telling you, you would just see it.
Yeah, I'm there.
Yeah, just email me and you know, come by and see. And because what I see, and you know, it applies to everybody. Look at posture, right? You do posture, okay? It's ridiculous. People plan MMA surgery by a natural head position. You have to understand that in the patient who struggle with breathing, the natural head position is not natural, but you guys know that, right? I mean, if they're PTs, physical therapists online or whatever, yeah. I mean, they're always in this neck forward posture. That's the only way they breathe. So if you don't account for it and say, you know, so on the side, right? They always walk in like you sound. I just tell them, hey, just imagine you're looking at yourself in the mirror and stay nice and relaxed, right? They're always going to stand like this. Well, I can't see myself, but they're always going to stand like with their neck forward like this. Okay? Mm-hmm. If you were to cut off their neck and just take a picture of their face, they look like they're class 1. They're normal. There's nothing wrong with them. The minute you put them back here, I'm not going to show you mine because I look awful. You know they're freaking hypoplastic, right? And you're going to plan surgery from there. Once you restore breathing, their posture restores. A lot of them do, especially the kids. And then the older ones you can retrain. All right. So examination of nasal breathing is not about looking inside the nose. I mean, yes, you're going to see a bunch of nose hair and whatever it is, and that's not important, because what are we talking about? We're talking about sleep disorder breathing that has happened since day 0 until now. You don't need to stick in a speculum to see it. Asymmetric face, asymmetric mid face, and a forward neck posture, you're done. You don't even need to look in. I mean, you should look, but I'm just saying, you know that guy's struggling. Okay. Now, I'm in dentistry. For the longest time, it has been about the joint, right? You know, and that is important. But now, you know, I'm invited to some of these really old school, not to offend anybody on this group if you're part of those societies, but, you know, they're really into the airway now. And the only thing I want to mention is nasal breathing happens before your jaw joint develops. So I'm sure some people have jaw joint pathology, but I'm going to tell you that the crooked mid-face is going to mess your joints. So I would highly suggest you treat nasal breathing and maxillary asymmetry, and then your jaw joints, hopefully. Even see, in that situation, even if your jaw joint has an issue with resorption or whatever, you're just talking about an AP problem. Right now, you're talking about like I am totally messed up, like hell problem. And you guys know what happens, right? So you've got the narrow patient, okay, high arch palate, big tonsils, mouth breathing, crooked maxilla, mandibles crooked, now the jaw joint hurts, then the neck hurts, and you got a forward posture, then you have fibromyalgia, you go get tested for everything, you're borderline for everything, no medical professional is going to be able to help you, and then if you're unfortunately a woman, you're going to wait until after menopause to suddenly be diagnosed with sleep apnea, because unfortunately you're put on the same standards, you know, with a 40-year-old obese man, and that's wrong. We'll come back to gender and ethnicity. And then you'll be tacked on weird diagnoses like fibromyalgia. You know this patient, right? And it could have began with nasal sprays. Wow. As a 2-year-old.
Wow. I kind of got the chills. Like, yeah.
But it is what it is, right? I mean, you tell me that's not the patient you see.
Oh.
And let's throw in the kitchen sink. Then the narrow patient gets narrower because you gotta, you know, restore the bite. But you know they can't ever restore the bite because they always have these gaps and things relapse. And then now you know you're always blamed for not wearing the retainer, even though it's just because the tongue is trying to escape for dear life. Then you need the surgeon cuts the tongue but then the tongue's like innocent, you know. The tongue's like, I'm trying to save this guy, but I'm just getting cut, right? And then the tongue is cut, and finally you maybe get an MMA, but it doesn't work anymore because after the MMA, the tongue doesn't move either. And then you guys training the tongue will be like, the tongue doesn't want to move. Wow, now we got a hypoglossal nerve stim. You're going to power the tongue again. You just cut off the muscle. And then the patient's on 2 forms of antidepressants, likely one that puts them to sleep, one that wakes them up. No, really, right? It keeps going. Sure. This is what you see, what I see every day, and it's aggravating. It's absolutely aggravating. So my fellows would tell you, my eyes light up when I see the 12-year-old. I'm like, yeah, you know. Or I mean, I do have to screen for patients. I just can't see everybody because there's so many patients who need surgical help. So I kind of, you know, screen appropriately. But you know, when a young patient is on my list, I try to see them right away because I feel like there is a timing issue here. We can prevent so much down the road. Yeah. And I don't mean to hog the conversation because I know you guys all have to run, but I'm going to mention one thing. I know people talk about myofunctional therapy and the importance of this. Here's the deal. It is all about the muscle. Everything is about the muscle, right? You train nasal breathing to do dilation of the upper airway. That's a muscle. Right? When the muscle no longer moves, you put a hypoglossal nerve stim, you're stimulating the muscle. When you do MMA surgery, the tension that it gives for the upper palatal muscles is about muscle, and the tongue should follow, right? In clinic, I have another horrible analogy, and it's really bad, but it works, okay? At my height, and I'm 5'8". I know on Zoom I look like I'm 5'11", but you know I'm 5'8". I cannot dunk a basketball no matter how hard I train. There are people who are my height who can do that, but I can't. Okay, but if I were to grow an extra foot, right, and I train, then I should be able to dunk the basketball. So it's all in the end not just about height. It's about muscle strength. Inherently, some people's muscles are stronger. So it's not like every class 2 patient or every maxillary hypoplastic patient you have to necessarily do something, because inherently maybe their muscles are stronger, or with minimal training they can dunk a basketball. But I can't. So I need a little bit of something on top of muscle retraining. So myofunctional therapy almost to me is like, we're talking about it because we want everybody to understand, but it is as fundamental as nasal breathing. It's just what you do. You talk, right? You swallow, right? You know, there's the same muscles implicated in sleep apnea. You know, I always have to remind patients of that. Sleep apnea is not about looking at the airway. That hole has no interest. Remind me to talk about the ultrasound again. That hole has no, it's not interesting at all, really. It's the muscles around that hole that is very interesting. And so everything we do turns out to be something that trains the muscle. Okay, so if you only fall short by X amount, you just need to do whatever it takes to get there. If you really fall short, then you might have to do more to get there. In the end, all surgery leads to myofunctional adaptation. Therapy is really just a way to get you that adaptation the fastest and most effective. And this is really true. I mean, you guys have to kind of start to try to look at it that way. And it's really easy to see.
I'm getting muscle fatigue because I can't stop smiling.
Sorry, I thought you meant fatigue because like this is so boring of a conversation. But
no,
guys, this is
hurting because I just can't. Everything that you're saying, my lord, this is so good.
But it's so common sense, right? I mean, how is this different than dunking a basketball, right? I can't do it. Some people can, but not even if I train really hard. And guess what happens? As we age, it's harder, right? Well, that's the same thing as
exactly.
That's the same thing as adults, right? And, you know, with the asymmetry, right? Walking with one long leg and one short leg, you know, one hip's going to hurt, then the other one, and both hips are going to hurt. All the muscles are going to be weird, and the back hurts, and the posture's off. It's not very different than what we do here. It's not very different. Now, you can say Stanley, you're oversimplifying things. Well, in some ways I am, in some ways I'm not. All I can do is restore form. There is a lot of research on, you know, then how this is ultimately, you know, the brain at some point has to trust that the airways better before the brain will let you sleep. Okay, so there is so much more to it. But don't tell me, don't delve into the super complicated stuff when you don't even restore the simple stuff at first, right? You know, that's kind of you know, that's not quite right, because we're talking about sleep. This is not a rare condition. And by the way, I hate talking about my sleep patients as being patients. They only become patients after the medical profession basically makes them a patient. All right, because whether you're a championship sleeper or a bad sleeper, everybody wants to sleep better. And sleep is one of those very basic conserved function. So we're not patients. We all want to sleep better, and we all can. It's about optimization of sleep and wellness. I really, again, dislike even talking about sleep disorder breathing as a disease or condition. It's a disease because you have to bill for it, and it's an insurance issue. But ultimately, like, can you deprive someone of their right or their need to sleep better? Absolutely not. So I don't like to talk about them as patients. Just, I mean, as an aside.
I love that.
This is so great. Okay, Dr. Liu, you have to come back. You're not, wait, I can't see you on my screen here. You're not. Will you come back? Because I have so many more questions. Can we talk to you again? Yes.
You guys can talk to me anytime. You know, time rolled really fast for me. At the same time, this is stuff that I share with patients every day. There's nothing here that is, again, we can all delve into all the papers, and it's not like I don't write. It sounds like I don't do research, you know, but at the same time, some of this stuff is very fundamental. So very, very happy to talk about it whenever you guys want me back.
For sure. And I'm gonna have you talk about one last thing before you go.
Sure.
But to kind of sum up some of like the main points I felt is early intervention is key. That's number one. Number two, the nose. We must not ignore the nose from an early age on, right? The nose will kind of shape the face and nose breathing, and the importance of muscle tone, correct muscle use, correct function. So those 3 points were really reinforced to me. When you come back, some of the things I want to talk about is upper airway resistance syndrome and MMA surgery, but you can't answer it now because we don't have time, but I really want to know thoughts on that. UPPP, other soft palate procedures, DICE, the Inspire hypoglossal nerve stimulation. These are things that I'm really curious about. Talking also a little about turbinate reduction and procedures like that. But before you go, I know you wanted to talk about the ultrasound technique for viewing airway muscles 1 year, like future thoughts for research. So I don't want to leave you hanging. You got to tell us about that.
Yep. Great, thank you, Nicole. And so yeah, two last things. First of all, we're barely scratching the surface. One of the things I've been working very actively on is gender and ethnicity. We can have a whole session on that, because guys, remember, women and young adults are the most underserved in this entire fabric of problems. Because remember, people like to go off this AHI. We can have another discussion on AHI and what is real sleep breathing disorder and what isn't. Okay, but just remember that based on what we currently know, right? We remember there's 5 to 15 is whatever, and 30 is severe, and then pediatrics. The minute you turn 18, the whole scale changes, right? It's like what the heck? But here's the thing. Do you think it makes any sense? So, I mean, we publish on this, right? For a lady who is as fatigued and tired and sleepy as their male counterpart, their AHI may only be 1/3 of the guy's number, okay? But because of this classification, most women are undertreated, grossly underdiagnosed and undertreated. So you know what's going to happen? Just like the kids who had the ADHD, but they actually just didn't sleep, right? You have the depression and the anxiety. Okay, because your AHI is too low, you can't have a sleeping problem, and you must be low on vitamin D, and like I said, you must be on. So in my clinic, 3 times the odds of a female patient to be on the antidepressant and anti-anxiety medication. I think that's wrong. I'm not saying people are not depressed. I'm just saying sleeping poorly doesn't help them, and women are super underserved. And then they hit menopause, and suddenly the airway is the same as a male's airway in terms of collapsibility. And then suddenly they have like severe sleep apnea. And this will segue into your upper airway resistance syndrome population. And if we don't have a separate criteria for women and men, we're going to run into forever issues. And then there's ethnicity. Ultrasound, why does it matter? Okay, so I did this biodesign fellowship at Stanford. So we think about medical, again, I write the boring academic stuff, but we have to think about what is a true need. Okay, a lot of times we have technology in our hands and we go look for things to apply to, and cone beam CT would be a good example. Cone beam CT has a lot of good uses of like bone and whatnot, but it's just not a great way to look at the airway, because all you see is a hole and a black hole. Okay, and it's okay, it gives you some information, but what the upper airway is a bunch of muscles. And you have to have the ability to see muscles. Now, of course, ideally you have MRIs, and also you're sticking needles in there to look at their EMGs. We're not going to do it. So we have newfound ultrasound technology that we're working on with machine learning capabilities to look at muscles. Why is this important? Well, I'll just give an example. First of all, it's non-invasive, it's point of care. Patients can come to your clinic every other visit, and you can put an ultrasound there and just kind of take a look at how their muscles are working. If I had a way to measure how strong they are, how disorganized they are on the cellular level, you know what you're working with. You know, and you are seeing improvement in this non-invasive form, where nowadays the most convenient ultrasounds you can get, you can plug into your cell phone and be looking at it. So that is a situation where you have a need and you're finding the right technology for it. So just kind of, you know, keep that in mind. Always remember, again, going back to the basics, always remember what the patient's needs are and develop the technology or the tools necessary to address it. And I think we have a lot more to look forward to in the years to come. All right, kick me off this. In fact, you could just wipe out the Zoom.
Okay.
You
Well, there's
know.
actually one really important question from, I don't know if Renata saw it, it was a little earlier.
Yes.
You're clearly incredibly smart, do tons of research. Is there a way you could find a way to clone yourself? We need another multiple Dr. Lou's. Someone asked, is there a way to clone you? You'll figure it out.
I understand that's a really, really nice comment. I appreciate, you know, that comment. But I do think my mission is this. Remember we talked about this pod idea? If I can train enough surgeons quickly, and I know where all of you guys are, what we have then is around this country, we'll have regions where we have this group, and this is where maybe the Airway Circle is probably you know, a very good place to start. If we have this, okay, then there is so much more we can do. So what we really want to do is actually clone common sense, clone our drive to look at things in a very systematic, logical sense. I mean, just 2 cents about myself. I was born in Taiwan, grew up in Istanbul, went to boarding school. For me, everything I do, I see similarities before differences. And I know there are practitioners who always want to say they're more important, or sorry, more different, and also more important.
Yes.
But that's not the point, because you are not more important. And all differences in opinions, you know, may apply to some patient, but we do need these little groups of practitioners around the world to make this, well, a better place. Happy world, right? Sound mind, happy world.
Yeah.
World Sleep Day. Let's remember that. So if we can all work together, you know, on that, I would be super stoked. And our patients need it.
We're so thankful for your time. It's so amazing. Renata, did you want to go ahead?
I just wanted to say thank you, Nicole, for always bringing the best guests to your podcast. Thank you, Dr. Stanley, for being here and sharing so much so candidly with all of us. Guys, this is going to be available on the podcast very soon, next month. Please share this podcast with your friends. Share with your colleagues. The more people that we can get to hear this information, the more patients we're going to be able to reach. So with that, I just want to end in happy World Sleep Day. Everybody go to bed early. Have a wonderful night. Thank you so much for being here and for supporting everything that Airway Circle is trying to bring to you.
Thank you guys very much.
Thanks
Bye-bye.
so much.
Thank you.